Hello again. Another short but nice case. This is a friend of mine who had an accident, a ski accident, and came to MRI quite fast after the accident, in 2 or 3 days, I think. What can we see? We see the anterior cruciate ligament, the ACL, which is torn. There is an avulsion of a bone fragment from the tibial plateau. You can very well depict this avulsion here. Okay, this is the fragment, and you can appreciate it on axial also. There is quite large area of bone which is slightly elevated from the tibial plateau. Posterior cruciate looks fine. Minimal inflammation of the medial collateral ligament, a lot of fluid around the knee, and inside the knee there is fluid level, so there is hematrosis on this sequence, which is a double oblique for the integrity of the ACL. You can see that ACL is quite intact, but the bone fragment is elevated. Of course, when this happens, usually it happens because the ligament is stronger than the bone, so you would not expect to have also ACL fibers which are torn. No, ACL fibers are okay, but the bone is avulsed from tibial plateau. Anyway, this should be quite an easy surgery. Usually it is a happy outcome because there is bone-to-bone healing after the surgeon will drag this fragment with a wire through tibia, and then the bone will heal bone to bone and will not require ligamentoplasty. I have a couple of cases of this kind which the patient recovered quite well. On this T1 you actually can see there are 3 layers. This is blood, this is fluid, and this is fat, consistent with this fracture. So the patient had surgery and she came after 8 months or 6 months, I think, came to MRI for a follow-up. What can we see? Perfect healing of the tibial plateau. The bone is very well inserted back in its place. Very small amount of irregularities here. This is the wire, but actually the fragment looks nice. ACL look nice, PCL look nice. Everything looks alright, except the patient cannot extend or flex the knee more than, I don't know, 15 degrees, and it was very stiff. Clinically, she had arthrofibrosis, one of the most important arthrofibrosis that I've seen clinically, and we can appreciate on these sequences that the whole capsule is quite thickened. There is fibrosis here in the Hoffa pad, and we also administered contrast. This is a high resolution sequence PD that I did in order to see the fragment and also to see the synovium. And after contrast administration, we see that everything here and in the back enhances with contrast, and this is due to fibrosis. It's a bit atypical to have this sort of fibrosis, which is not usually. You see a cyclop eye here, nodular fibrosis. This is extensive fibrosis which encompasses the whole knee. We try to figure out why this is happened, because most of the rehabilitation took place in normal fashion. The problem was probably that she had to stay immobilized for couple of weeks after the surgery in order to give time to this fracture to heal. And this prolonged immobilization might be the cause for this arthrofibrosis. The surgery went perfectly, but unfortunately the patient developed arthrofibrosis and she needed a second surgery. I will keep you posted with the follow-up. Thank you. If you like my content, please share, like, subscribe, and give me suggestion if there are some things you want me to improve. Write me comments or messages. Bye.